Subbarao sir. Tangapati Subbarao sir joined.
Sir joined. Sir joined.
Welcome, Subbarao sir. Okay. So it's around 8:02. Shall we start the program, sir?
Yes, Raj. Yes, you can.
Yeah, once again, I'm welcoming you for this 31st session of Peculiar Case Series in Renal Transplant. And it's like yesterday we started the program that it has run through years. Actually, it was around 2.5 years we have crossed the program. We have this platform. And 30 meetings are successfully completed. And this is our first meeting of 2024. And this meeting, as usual, consists of two important cases. And this time by a veteran in nephrology, who is a veteran in nephrology, who has been practicing for more than 35 years and transplant for 35 years, is going to present his own experience on some important nuances of using a basic drug that is tacrolimus. So it's going to be, I hope that it's going to be a wonderful meet. To kick off the meet, I just want to introduce our speakers. First is by Dr. Soundrapandian sir. He's he's a senior consultant nephrologist at Apollo Hospital, Madurai. And his experience is vast. Actually, he's the first one who started the transplant in 1984, actually, probably after CMC Vellore. And he has been doing an active transplant since then, actually. So he has more than 500 to 600 transplant to his credit. And he has been awarded as a Lifetime Achievement Award from the MGR University and also from NATPU. He, along with Dr. CMT Tyagarajan sir and Dr. Rajan Ravichandran, has made that time, that was a period of developing transplant sciences with no definitive protocols and all. They have their own way of starting the drugs of a cycle. They have seen an era that is yesteryears and now years, and they have seen a 3 generation of renal transplant, and they have started from cyclosporin, tacrolimus and all. Has a vast experience, a practical experience, what you call as a practical experience, how to deal with this immunosuppression, basic immunosuppression, which we are struggling actually. Higher the dose, we land up in ATN. Lower the dose, we start having a rejection. And still the optimal dose also, we are seeing many cases of ATN and all, what to do and all. So how low we have to see. We have a Western data of having a TAC level like this month, but this holds for our group of patients, only experience will tell. And sir, I definitely we owe to listen to you for your experience, how far you have come across with this hurdle of using the transplant immunosuppression. Second presentation is by Dr. Srijit Parameshwaran, and from JIPMER, and we all know that he's all over India renowned nephrologist, and he doesn't need any introduction from the extra introduction in this group. Actually, he has presented previously 2-3 excellent presentations in the last 2 series actually, and he has a lot of accolades actually, and he's nodal officer of JIPMER Disease Donor Transplant Program, and he's the member of Super Specialty DNP Program of India and program, and he's the one who established the Department of Nephrology in the JIPMER, and this department is doing a long strides in the past, for the past 15, 20, 10, 12 years and all. And he's being the young achiever. He has awarded a Tanker Award in 2015 also. And he's a well-renowned academician and very crisp. He's crisp in ideas and thoughts, and his knowledge in renal transplant is somewhat we are very much looking upon for it. And the panelist for this session of meeting is I'm privileged to introduce Dr. Subbarao sir, from Senior Consultant Nephrologist at Head Nephrology, Apollo Hospital, Chennai. Sir is an active participant of this program, the renal transplant, and in our group also, and he has He came as a panelist before also, and he's very much, he's a vibe. His vibe is, yeah, it is somewhat extraordinary. And he's a very good academician, and he has trained around more than 30, 40 DNB residents in Apollo, and he's very much interested. He's a team member, and even in Apollo also, whenever a team member gets his problem in a transplant, he's there to help them, and he will always there to share his expertise. And here also we expect his inputs regarding these two cases. And we are very much obliged and privileged to introduce. I'm privileged to introduce Dr. C.M. Tyagarajan sir, who is about to join in this meeting. He was traveling. He's traveling somewhere, and he'll be. Hope we'll be meeting him. And CMT sir, along with Soundarpandian sir, is one of the pioneers in nephrology in Tamil Nadu. Has started renal transplant program. He has a lot of credits to renal transplant. Actually, more than 1,000 renal transplant he would have done. And for any complication, you say that he would have came across, and he has some inputs. And CMT sir, along with Soundarpandian sir, has pioneered in tacrolimus dose reduction. Actually, tailoring the dose of tacrolimus. And they have the good science behind doing this. So without wasting much of the time, over to Dr. Soundarpandian sir for your presentation on this. The time of presentation is 20 minutes, and we'll have a 10 minutes of discussion. And over to Soundarpandian sir. Please share your slides, sir. Soundarpandian sir?
Yes, sir.
Yeah.
The key
Okay. Okay, sir. You can go ahead.
Good evening, Dr. Rajarajan and Dr. Vel. I am new to your presentation today, but I have been silently watching your activities from behind and wondering about this wonderful group of nephrologists that you have organized. It's a tremendous work. I thought it was some small doubts here and there in nephrology practice, but the way it is enlarging and the way it is rendering service, I am just amazed, and I have great pleasure in joining your forum for a talk today. Well, Dr. Rajarajan has given a brief glimpse about my career, and I am a student of Madras Medical College under Dr. Amaresan, and along with my teammate was Dr. Soundarajan, who is a known nephrologist to you all, and then Dr. Muthu Jayaraman, who was my teacher under Dr. Amaresan. When I was doing DM, she was my teacher, and many others subsequently. Dinagaran, who came next batch to me, and Sambat, who came much later. Now about the topic. I'm going to talk today on low-dose immunosuppression. How low is low? Some people have attempted low-dose immunosuppression, but how low is low? And what I'm going to present to you is probably my dosage is the lowest ever recorded in the world literature. And some of the facts I'm going to tell you may raise your eyebrows. Some of you may be surprised. Some of you may be shocked about the way I'm giving immunosuppression. I'll go for the next slide. Yeah. If you consider the immunosuppression over the years, what is the evolution? In the 1954 was the first transplant. In 1950s, attempts were made, and the initial immunosuppression was by total body irradiation. And the first drug that was given was steroids. Steroids till 1960s, there was no other go. Total body irradiation and steroids. Azathioprine came into the field in 1960s, and it was there from 1960s to 1980s. For 20 long years, it was all steroid and azathioprine. And I had used the same for my probably first 100 cases, only these two. And I was quite happy with these two. ATG came later in 1970s. And this present triple drug therapy was started in 1980s with the advent of mycophenolate, then cyclosporine. Then came tacrolimus, sirolimus, and basiliximab. And the question was, why you have to give 3 drugs? It was mainly to prevent acute rejection in the early stages and improving graft function, prolonging graft survival. And when you add more drugs, individual dosage can be reduced. Each drug is what is happening in diabetes, in hypertension. You no longer give 1 drug, but you give 3, 4 like that. It was called a polypharmacy in those days. It was ridiculed in the beginning, but now everybody have come to accept polypharmacy in diabetes, hypertension, now in transplant also. It is supposed to have a cocktail effect. The cocktail effect is like this. The word denotes that it's a combination of 3 different kinds. You see here a beer bottle with probably a whiskey small amount, a brandy small amount, and beer small amount. If you add these 3 combinations in small amount, the effect is hectic. Those of you who have experienced it will feel it. Those who have not experienced it, please try. If you want to get a good kick from any of these individual entities, you have to take 3, 4 pegs of whiskey. But when you go for a cocktail, a little whiskey, a little brandy, and a little beer will take you by helicopter heights. So that is the idea of cocktail. What is happening in this combination is happening in medicine also. This is what happens in diabetes when you give 3 different combination of drug. This is what happens in hypertension, and this is what is happening exactly in renal transplant also. And then cyclosporine, it was invented in 1983. The initial dosage recommended was 17 milligram per kilogram per day. You'll be surprised that cyclosporine was invented when I was doing my DM. And just before I started DM, I read about cyclosporine in a journal. It was not in the textbooks. So I read about cyclosporine in the journal, and there was a question, essay question for me in DM nephrology. And I wrote 17 milligram per kilogram, and I passed my DM with that dosing. But when you come out to the field, you find nobody is giving 17 milligram per kilogram. My God, what is that 17 milligram per kilogram? Nobody can afford and nobody will tolerate. So the dose came down by down, 8 to 10 milligram. Then it came to 2 to 5 milligram. The credit goes largely to one of our panelists, Dr. C.M. Tyagarajan. So when I started transplant in those days, I heard that C.M. Tyagarajan was doing a lot of unrelated transplants, and he was mainly giving cyclosporine as his weapon. So one day during a conference lunch hour, I called C.M. Tyagarajan aside and asked him, why is it that you are giving such a 3 milligram per kilogram dose, but the books say, or the journals say it is 17 milligram per kilogram. And what C.M. Tyagarajan told me at that time, this happened many years ago. What he told me at that time, Adapoya, the dose. It's all for Westerners. For us, this dosage is enough. And he was giving cyclosporine, and he was getting on well. And I took the title of this talk. I took it, I owe mainly to Dr. C.M. Tyagarajan. I told him so today morning. And Next is tacrolimus. It was invented much recently, 1994. And the initial dosage was, say, for a 50 kg man, 7.5 milligram per day. And then the maintenance dosage was 2.5 milligram per day. This is what was recommended all over. Now we'll come to an important question. How do you assess drug adequacy? It is by dose response, not by anything else, not by drug level. How do you give a drug, whether it is good, whether it is adequate, is all, how do you assess? The basic concept is that the amount of a drug required to produce a desired response. For example, paracetamol, you give 500 milligram, it should bring down the body temperature to normal. That's all. I don't care what is the level of paracetamol in the blood and all that. I care hoots. I only want the temperature to come down. This is the dose response. And it means if you give very low dose, there's no response. If we give very high dose, no additional effect, but may lead to adverse effects. This is a dose response curve. You find in this range, no effect. And in this range, you increase the dose, you start getting response. Once you reach that maximum thing, there is no further additional benefit, but only you get into complication. This is what is exactly happening to tacrolimus now. You give, okay, if you give appropriate dose, you get a result. If you trespass that limit, you get into problem. And for example, how do you assess drug adequacy in hypertension? You record BP regularly and you know whether the drug is adequate or not. If the BP doesn't fall, you increase the dose or you change the drug. What happens in diabetes? You monitor blood sugar regularly, fasting, postprandial, HbA1c, and see if the blood sugar is not controlled, you increase the dose or change the drug or you combination and all that, not by any drug level. And infections, same thing. And how should you assess drug level in transplantation? No trough level for steroid. I told you for the first 10 years, it was all steroid. Next 20 years, it was all azathioprine. And now, MMF. You don't do trough level for any of these drugs. Steroid, azathioprine, MMF. None of these drugs you are doing drug level. And when cyclosporine was introduced, some people started talking about trough level. So it was started rather half-heartedly, but nobody really did the trough level. And for tacrolimus, trough level has been made mandatory. Why? Why? That's my question. Now I'll go through a few words about my experience. I did my first live donor transplant in 1987 in Madurai, in a private hospital. There was no Apollo at that time. There was no Meenakshi mission at that time. And there was no other nephrologist except me in Madurai. So I did my transplant in 1987. I have completed so far about 500 or so. And regarding this, I must tell you, when I started transplant, we were not taught transplant in our college, Madras Medical College. There was no transplant at all. And so there was nobody to teach me. And there is a Dr. Seduraman, Madurai, a famous urologist, the founder of Meenakshi Mission Hospital, where Dr. Sampath is the chief nephrologist now. He and me are friends. He asked me one day, Doctor, we have come out with qualification in kidney. People will expect a lot from us in Madurai. They will ask, are you doing transplant? You have not done, I have not done. We must do. So we decided to go out somewhere and see transplant. On weekends, he used to come with his Matador van, and he and I traveled to CMC Vellore one day, and then Chennai Guest Hospital. Like that, a few places we went every week and then saw and learned. What I learned from those places is that no two centers have same schedule. Everybody has their own protocol. CMC Vellore has their own, Apollo Chennai own, and CM Rajan had his own. So I was baffled. There is no guideline at all. And so we decided to do my own protocol. And I used only prednisolone and azathioprine for the first nearly 100 cases. I started using MMF and cyclosporine nearly 10 years later. Now I'm using triple immunosuppression, prednisolone, MMF, and tacrolimus. My induction is like this. My induction is only for unrelated or cadaver transplant. Others, I don't give induction. And that too, a simple thymoglobulin 50 milligram IV to start the transplant. Then triple drug started 1 day prior to transplant as induction. And then on the day of surgery, methylprednisolone 1 gram IV for 3 days, and then followed with the tablet prednisolone 40 milligram OD, and then tapered off slowly. Tablet mycophenolate 500 milligram BD. And please listen, tacrolimus 1 milligram BD from day one. Only 1 milligram BD from my first transplant till now, till today. And how I assess drug adequacy in my cases. By clinical response, my patients, they put out urine adequately, say 4 to 5 liters per day, and their blood urea and serum creatinine crash by day 4 or 5, and all are discharged by day 14. What else I need and what else you need? That's a question. No trough level for any of my cases. Please remember, I don't do trough level for any of my cases because I don't believe in that. You see, as I told you already, you don't do trough level for most important drug, steroid, and no drug level for azathioprine, which ruled the transplant scenario for 20 years, and no trough level for MMF, and why the hell for tacrolimus only. Now, the trough level is not the ideal reflection of systemic exposure. There are many papers questioning the validity of trough level. They say area under concentration over time, AUC, is more reliable and accurate than trough level. Some may show high AUC with the normal trough level, causing unintentional overdosing. That's what is happening in many of the cases. And so AUC is the best marker, but expensive and not practical. And now I will give you just a few cases in my practice to authenticate my theory. This patient, Michael Roy, I did transplant in 2012. His wife donated the kidney. It was uneventful on the table and brisk diuresis. As I said, because wife is considered unrelated, though she is related, it is not biologically related. So I considered her as an unrelated. I gave thymoglobulin 50 milligram at the start, then followed by the triple drugs. And in those days, initially I was using cyclosporine. This is 1 ml BD, that is 100 milligram BD to start with. Then it was brought down to 0.75 BD, and then it was 0.5 BD. And we gave cyclosporine for 1 year and then stopped. In those days, I had a little talk with Dr. Rajan Ravichandran. I don't know whether he is in this group today, but I had a talk with him at that time, and I had a talk with him today also. I asked him how you give cyclosporine and how long you give cyclosporine. He told me the patient develops, if at all, any complication, acute rejection in the initial period, say 6 months, maximum 1 year. So you have to be careful at that time only, because people will question you. You will be answerable to the patient and relatives for the first 6 months to 1 year. After that, everybody will go away on their own, and nobody bothers what happens. If something goes wrong after 6 months, 1 year, they won't attribute anything on you. So you have to be careful. That's why I am giving cyclosporine, and I give for only 6 months to 1 year and then stop. Like that, this Michael Raja stopped after 1 year, and he's still on only 2 drugs and nothing wrong. He's happy. He came to me about a week back. The second case was a lady who was on dialysis at Apollo Karaikudi, and her husband volunteered to be a donor. And the transplant went on uneventfully, same thing, thymoglobulin, and then the triple drugs. Post-operative course uneventful, output up to 8 liters per day, urea crashed to 28, creatinine crashed to 1, and I discharged her promptly on 14th day. She is still attending my OP regularly once a month. And this girl, 12-year-old school girl at that time, Divya, she had a transplant under me in 2014. Her mother was the donor. And since the mother was the donor, I didn't give any induction. It's only methylprednisolone and the 3 drugs. And the dose was tacrolimus 1 milligram BD. Post-operative course was uneventful and the values crashed. And she is still attending my OP. She finished her school studies. Now she finished her BCom, and now she is going for higher studies. This lady, Vasanti, was undergoing dialysis at Apollo Karur. Karur also came under my jurisdiction in Madurai. And she was registered for cadaver transplant. I did a cadaver transplant for her in 2020. I gave her same induction, thymoglobulin 50, and then the immunosuppressive. It was in 2020. And on the table, there was a urine output was sluggish on the table. And I started around my favorite prescription, dopamine, 3 mg per kg per minute, and injection N-acetylcysteine, furosemide. And the output picked up very next day to 5 liters per day. There was a sluggish output on the table. And this was a cadaver transplant. No wonder that the output was sluggish. And then on even this case, this cadaver transplant, discharged around 14th day. For 2 days, I was away, and my juniors, Dr. Arun Prasad, who was looking after the case, he said, "Why you are not seeing TAC levels, sir?" So he asked for a TAC level. It was 3.7. He asked me, "Is it not low, sir?" I said, "It may be low, but the urea is 28, creatinine is 1, and the urine output is 8 liters. What more you want, Arun?" That's my answer for all your queries also. And this girl, Divya Prasanna, she was undergoing college course, and there was no donor. She was undergoing dialysis at Vel Arvind Hospital, Madurai, and did a transplant in 2019. Procedure was uneventful. As usual, I gave thymoglobulin and the triple drugs. And urine output was sluggish on the table. It's a cadaver transplant, poor output. And it was a delayed graft function, ATN. As usual, my favorite prescription of dopamine infusion, low dose. Now, please listen. Dopamine is under fire of late. Many people, they don't believe in dopamine. Many people are contesting dopamine. But I strongly believe in that, and I strongly recommend to you, if you have early signs of ATN, please, without any hesitation, start on this. You will have no regrets at all. And the urea shot up after came to normal, it shot up to 61, and the creatinine after 1.1, it went up to 5.2. And I didn't do any biopsy and no dialysis, just this dopamine. And urine output slowly improved up to 9 liters per day. And the urea, which went up to 160, came to 22, and the creatinine, which went up to 7.3, came to 0.7. And this girl has now completed her postgraduate degree. She is doing MBA now in Madurai, and she is doing very well. Now, to sum up, low-dose immunosuppressives for all cases, tacrolimus 1 milligram BD, MMF 500 milligram BD, prednisolone as usual, and induction very rarely and minimally, and only with thymoglobulin. I didn't go for the high-tech brands now. and no episodes of acute rejection in the cases cited. In my other cases, see, for out of 500 cases, say first 100 cases azathioprine, next 100 cases cyclosporine and azathioprine. After that only we started tacrolimus. Now about 300 cases tacrolimus. Out of which, only 7% or less is acute rejection. So people say if you reduce the dosage of tacrolimus, the storm will be there. You will have acute rejection. Doesn't happen. Doesn't happen at all. It happens like any other way, any other situation. And it is always reverted with pulse steroid. All my cases of acute rejection reverted with pulse steroid. And very cost effective. What is the dose of cost of tacrolimus? And what is the cost of tacrolimus frequent monitoring? So my cases of transplant, they spend very little in the hospital and they are happy. And no regrets for not doing TAC trough level at all. I have had no regrets. Many people, many nephrologists, they find it hard to believe my statement, but that's the truth. And delayed graft function ATN invariably reverted with NS-16 and all that. That's a different topic. It's not adequate time for me to delve in that. When time permits and all that, I can talk about NS-16 in this situation. But I have had great success, and I will strongly recommend you all to follow that. And what is right or wrong with the high dose immunosuppressant? It is true that acute rejection is less when you give the high dosage, which all of you give now. But in the long run, nephrotoxicity, chronic interstitial nephritis is very, very, very common and is probably dubbed as chronic allograft nephropathy. When somebody starts getting creeping creatinine, I find in this group, many of you have come out with the history of creeping creatinine and you think of doing this, that. And then there was one member who commented, we are all chasing tacrolimus level. I don't know, I forget his name. But if he is listening, he may know I'm talking about him. He said, we are all chasing tacrolimus. That's what all of you are doing. I am not chasing. I'm sitting comfortably. And you know, chronic allograft nephropathy and the interstitial nephritis caused by tacrolimus, they are indistinguishable even if you do a biopsy. So you put the blame when something goes wrong, you put the blame on the chronic rejection, not think about that you are giving tacrolimus in high doses. Now, is there anybody on my side in the world literature? Because what I'm giving, I'm sure in India, nobody is giving. Any of you, none of you are giving this dose. So anybody else in the world literature? Yes, there are 3 trials. One is from Transplantation Direct in 2023 April. Somebody came out with 53 cases and they gave what they call low dose is 9 milligram and below. But what my low dose is 2 milligram per day. So they said the graft outcome are not significantly different at 1 year. So they give above 9 milligram per day and compare with less than 9 milligram. They find there's no difference. And this is a clinical transplantation, Justin Shuva. He presented 127 cases. Here, the low dose was 3 milligram per day and high dose was 4.5 milligram per day. His trial, the TAC level low at day 21 and the graft outcome similar at 3 years. The tacrolimus level was low on paper at day 21. After day 21, there is no difference even in the TAC level. And the outcome, graft outcome at 3 years was same. That is his presentation. And this is a Chinese work. In 2018, he presented this paper with 189 cases. He comes close to my level. That is tacrolimus 2 milligram one group, 2.5 milligram one group, and 3 milligram per day one group. Mine is 2 milligram. So he comes closer to mine. And he observes there's no difference in trough level after day 7 and at 1 year. He says if you do regularly trough level, it is low in the first 7 days, but not after day 7. And at 1 year, there is absolutely no difference in all the groups and no difference in acute rejection or delayed graft function. It is very safe and effective. That's what this Chinese author says. It's almost like my presentation. Only thing is, the difference is, I don't do trough level to convince you. That is, I don't do periodical trough level to convince you that trough level is safe, because I don't believe in this business of trough level for this one drug only. There are so many diseases, so many drugs, so many treatment. You don't see the effect of your treatment with the trough level. But why you should do that only? Now, who started this business of trough level? It was KDIGO. It's a kidney disease improving global outcome group. They gave this guideline of trough level that you monitor periodically, and everybody is following this KDIGO guideline. And there are reports which say that KDIGO guidelines, if you analyze in the total, about 65% of the KDIGO surveys are wrong. They are based on wrong surmises and wrong statistics. So this KDIGO guideline may not be given that much importance, is the final thinking now. And we are doing this trough level only on this group's advice, guidelines. Otherwise, you can comfortably do away with the trough level. Here is my appeal. You have to see my cases to believe. And you have to try a few cases to convince yourself and convince others. And a large prospective study is needed, because what I have done is a retrospective study. What you need is a large prospective study. I think if there is a large nephrology body in this gathering, if some of you take up this and prove to the world, it's a great thing. Thank you all. Thank you, Dr. Rajan. Thank you, Dr. Vel. And thank you, Dr. Subbarao, my senior colleague in Apollo Chennai. And thank you, everybody.
Thank you, sir. Thank you, sir, for your experience from past 37 years. Dear audience, sir has been practicing nephrology from 1984, and he has been doing transplant from 1987. And he has completed around 500 transplant, and he has painted a very rosy picture of low-dose tacrolimus. That are very we want to attain a holy grail of reducing the TAC toxicity at the same time to reduce rejection and also preventing infections also. Sir has quoted his experience of having a low-dose TAC and non-monitoring of tacrolimus trough level. Sounds exceptional in this current era of medical legal importance. And I will throw the discussion to the panelists, and we can have a consensus on this. Saris has a vast experience, and he's an perhaps first batch of DM nephrology from MMC also. So over to Subbarao, sir, your comments and about
yeah,
this.
I think when you compare with the cyclosporin with tacrolimus, the cyclosporin was started with very, very high doses. We don't be in the initial stages. That is because what happened was Roy Khan was the one who was studying this molecule in Guy's Hospital, England. And these experimental animals are Alsatian dogs. Unfortunately, or fortunately for them, they didn't have any nephrotoxicity with cyclosporin. So what happened was that with 15 milligrams of kg body weight, he could able to get a good immunosuppression in Alsatian dogs. So the same thing was when it was given to the humans, then he started experiencing the cyclosporin toxicity, which they never expected. In fact, if there was a toxicity of nephrotoxicity of cyclosporin in those dogs, the molecule would not have come into the existence at all. They would have dropped it out straight away. Yes. Fortunately for us, they didn't notice any nephrotoxicity in those animals, and then with the same dose they tried in humans, and then they got into trouble. That's where the 50 milligrams of kg body weight cyclosporine dose has come. And subsequently, over a period of time, where many studies have been done, and then we started reducing the dose of cyclosporine. So I think that is the story of why people were even the company was the Sandoz was actually marketing that drug, and they said the most therapeutic dose was 15 milligrams kg body weight. So that's the story of why we got high cyclosporine dose initially. Whereas that tacrolimus, they were very careful, so they tried in well before they released into the market, and they could able to adjust the doses and then the levels. And when Roy Khan was studied, he never studied the level of cyclosporine in the animals. He went by therapeutic efficiency. The other thing is that the low dose of CNIs has been there for many decades. I think the moment CNIs have come, the thing that was seen by the most of the nephrologists was that the propensity to produce nephrotoxicity. So there was always a guarding against the use of very high dose CNIs, and then with the help of the other drugs that was already in the market, so in the beginning, they could be able to reduce the dose. So the low dose cyclosporine, usually people will give a high dose steroids initially, or give a induction therapy like with ATG or something like that, and then reduce the dose of cyclosporine or any CNS over a period of time.
Thank you, Subbarao. Sir has racked one question, interesting debate, like we don't monitor for steroids, we don't monitor for azathioprine, we don't monitor for MMF, though AUC was there. So why for...
I also don't do, I do it, but I usually probably do four levels in a year. On the 4th day, on 30th day, on 3rd month, and 1 year. That's all. If there is no issues. If there is an issue, then okay, then I will do the level. But if there is no level, I don't do it every weekly or monthly like that. So my first level will be on the 4th day, second level will be on the 30th day, the third level will be on the at the end of 3 months, and the 4th level is at the end of 12 months.
Okay.
So if I could go get away with 4 levels, I think Saundar Pandyan was with 0 levels.
Okay.
Thank you, sir.
Thank you, sir. Any other comments? Dr. Srijit, your comments on this?
I come from the other end of the spectrum, where we frequently monitor the TAC level, immediate post-transplant especially. Primary reason is that it's available free of cost and patient don't pay for it. And we keep a higher level. So, but the regimen we follow is also completely different from what sir is using. We use a dose of steroids. Just give one 500 milligram dose of midoprenizole intra-op, followed by dexamethasone. So, and then we start with a 20 milligram prednisolone. So the dose of steroid used is significantly lower, and we don't use the induction uniformly, but that is tailored to the immunological risk assessment based on multiple tests we do, cross-match and DSA and all. But the TAC levels, I can understand what sir is saying, but what we have been doing is to monitor the levels, and we keep the trough levels higher. I am not sure whether the sensitization and sir will be using the same. Suppose somebody is sensitized, in that will the protocol be? I'm curious to know, because that data seems quite interesting. If somebody is sensitized and then you do transplant, and sir was saying that the dose is probably similar for deceased donor and living donor. That I would say it is quite interesting. Worth looking at what exactly is happening, and it's quite possible that the TAC levels, trough levels recommended now is higher than what is necessary. So it is definitely worth looking at. I completely agree that we need more data on this. Thank you.
Definitely. Actually, we are not open to this. Actually, we are believing the Western data and all. We don't have probably a optimal dose of tacrolimus studies and all. I think Sarah's racked up a new point of seeing the tacrolimus in a different way. And his paper and his stats also interesting.
There's the interaction between the steroids and the CNIs. A higher dose of CNI actually increases the the availability or the utilization of the CNI. So if you give a little higher steroids, the CNI dose can be substantially reduced, but at the same time the efficacy can be increased. So there is people who reduce the cyclosporin or CNIs to very low, but they will give a little higher steroid we usually give. We usually bring it down to 5 milligrams, 7 milligrams at the end of 2-3 months. But the people who give very low CNIs, they give a little higher dose of effect, because that will increase cyclosporin. So the mechanism of cyclosporin gets enhanced. So there is a link between these two.
Definitely. So it's interesting. And just one question to ask: like, I had a patient. Everybody would have experienced this patient with the creatinine not coming to normal. It was 1.6 to 1.7, 1.9 is hovering around that, and your TAC level is optimal. And if you do a biopsy, it shows ATN. And within 1 or 2 months of transplant, in that scenario, what you will do? Whether you will reduce the tacrolimus or you will continue the same dose. Biopsy is ATN, creatinine is like creeping 1.5, 1.6, it's not settling down, and TAC level is optimal, and biopsy is ATN.
The thing is, the problem comes only if there is a graft dysfunction. If there is no graft dysfunction, none of us will going to tamper the dose of any of these or immunosuppression. We'll go by our standard protocol. So but if there is an incidence of any acute kidney injury or an acute rejection, then only we sit back and look at where things went wrong, where things have been has to be modified. So here, probably the first thing what we all do is, even I think everybody does it. The moment you see no rejection on the biopsy, only acute kidney injury, if there is no proof of any other insult to produce an acute kidney injury, is to a little lower the dose of CNS and monitor. So that's everybody does it. I think that's a very practical point. That I don't think anybody will disagree.
Okay. As we are running short of time, and it was an interesting first session, and if no further questions, we have answered some chat questions also. So we will move on to the next topic, and this is going to be presented by Dr. Shethit, and this is over to Dr. Shethit for your presentation, please.
Thank you, Rajan. Actually, the case I have asked my final year DM resident to present. I hope that's okay.
Okay, sir.
Dr. Piyush will be presenting on behalf of the department.
Thank you, sir.
Thank you.
Good evening, everyone. Sir, whether my screen is visible, sir?
Yes. Go ahead, please.
Good evening, sir. So this is a lady which came to us for evaluation for living kidney donor evaluation for a daughter who was diagnosed as CKD and was on maintenance hemodialysis. And while on evaluation, something unexpected came on evaluation. So she was a 52-year-old lady, apparently healthy. P4L4, last childbirth 24 years back and postmenopausal. Daughter was diagnosed as ESRD at the age of 23, and while she was initially was evaluated for systemic hypertension and found to have shrunken kidney disease, so biopsy was not performed, and a clinical impression of the basic kidney disease was kept as chronic glomerulonephritis. So her basic general and physical examinations were within normal limit. BMI of 24, BP of 130/80, no known comorbidities, no history of any surgeries or allergies, and no DM hypertension. Routine evaluation, CBC, sugar profile, lipid profile, viral markers, liver function test, no proteinuria, nothing was there. So we went ahead with the chest X-ray, that was normal. Ultrasound was done, which showed normal size kidneys, normal CMDs, and liver was showing one small cyst and was having mildly altered liver echos. Other than that, ultrasound was normal. We went ahead with doing GFR. GFR was done by plasma clearance method, and she had a normalized GFR of 101 ml per minute per body surface area with a differential GFR of 48 and 52 of left and right kidney respectively. We did all the pre-donation evaluations from various departments, cardiology, psychiatry, gynecology, all routine evaluation was done, and they have cleared the patient. For medical gastroentero, we have taken evaluation reference for that anechoic cyst, and for that mildly altered echos. After evaluation, they also cleared the patient for the kidney donation surgery. Later, we did a CT angiogram before as a further step. And in that CT angiogram, we found out that there are multiple small cysts in both the kidneys. Largest size was around 8 cross 7 mm and 6 cross 6 mm, but there were multiple small cysts. Along with that, we also found out multiple simple cysts in both lobes of liver, largest measuring out 2.2 cross 1.7 centimeter. So these were not there in there was only one cyst in the ultrasound and no cyst in the kidneys in the ultrasound, but we found out this multiple cysts in livers and kidney, which are small in size, but yes, they were present now. So I'll be playing this CT angio video so that we can see the cysts which are there in the liver. And also we can see subsequently the hypodense small areas which are visible in the kidneys also, which were not picked up on ultrasound. And this patient is also normotensive and also having normal GFR. And to evaluate the cyst, we did a clinical whole exome sequencing, and we found to have this mutation, PKD1 mutation, in the genetic analysis. So looking at the family history of this donor, she was born out of third degree consanguinity with 3 siblings and no history of kidney disease, and no history of any other kidney disease or other than 1 children. No other, all 3 children. She has 4 kids, one which is the CKD, and other 3 children were apparently healthy. So our final impression was a living kidney. She was a living kidney donor for daughter, found to have multiple cysts in liver and kidney with PKD1 mutation detected on genetic analysis, and likely ADPKD with liver cysts. So was rejected as a donor. Subsequently, other members of the family was evaluated, and an elder sister agreed to be the donor. She was 33-year-old female, asymptomatic with 2 uneventful pregnancies, and she was not affordable basically for genetic tests. So we did an ultrasound. Ultrasound was normal. Both kidneys were 10 centimeter with normal echos, no evidence of any cyst in liver or kidney. And subsequently, we did an MR abdomen for this lady, and we found multiple cysts in MRI in liver and also in kidneys. So which was not picked up on ultrasound, which was the routine screening which we usually do for our patient. But since this mother had this issue, so we did MRI abdomen, and she was not and she was not affording for genetic testing also. So our impression was this is again a likely ADPKD with less severe disease, and decided not to accept the mother and sister, and she's now in our deceased donor transplant waiting list. So if you see the diagnostic criteria of ADPKD, all those who are high risk, at risk of ADPKD, that is having family history of ADPKD, we do a routine scan. In that, if the scan is of a typical presentation like kidney cyst are there, renal dysfunction is there, hypertension is there, liver cyst are there, then subsequently based on ultrasound criteria, we classify based on the age based on age base. We there are ultrasound criteria, and based on the number of cysts, whether they are having or not, we see. If the person is not having any unequivocal feature or atypical finding, in such cases, further imaging studies like MRI or CT has to be done, or in some cases, genetic testing has to be done. So the diagnostic criteria comprises of the number of cysts as per the age, and with the positive family history, it is almost around sensitivity and specificity are almost around 100%. But these criteria were made when there was no this only the classic 2 mutations were there. But subsequently, many other mutations were came out which are known to cause an atypical presentation rather than the routine one. So this is the ultrasound guided criteria which is there in the latest KDIGO guidelines. This is there for to diagnose for those patients who are having positive family history. As we see in this criteria, those with unknown genetic mutation, the sensitivity is less compared to those with PKD1 and PKD2 mutation. And the younger the age, the sensitivity of these criteria are less. Similarly, to exclude also with the family history, to exclude also, KDIGO has given a separate criteria, and for same as the age increases, the specificity increases. For patient for MRI for making a diagnosis, those with more than 10 cyst or total, it is sufficient to make a diagnosis, and people with less than 5 cyst can be sufficient for exclusion. So so therefore we did MRI for the elder sister who came for donor evaluation. So genetic testing, if we see, it is particularly important when the situation is not very much clear, when there is no family history is there, when the equivocal diagnosis is there. In that case, it is very important. Targeted next generation sequencing or any other clinical panel which is accredited by the ACMG guidelines should be done. And screening methods do not detect all pathogenic variants, and many of the variants according to ACMG guidelines are also not pathogenic. So there are a number of situations where we should be looking forward for the genetic testing, like the number of cysts are limited. When there is a variable disease severity in the family, in that cases, other than the routine mutation, we can guess mosaicism or a digenic disease. When there is atypical imaging, like only unilateral kidneys are there, or kidneys are involved, both kidneys are involved, but they are asymmetrically involved. When there is a discordance between the structural and functional, like kidneys are not that much involved, but there is significant fall in the GFR. When there are negative family history, no history is there, and multiple cysts are there, and then we found to have one de novo mutation in that family. When the onset of ADPKD is very early in the second or third decade, where we are not expecting that thing, especially when evaluating for the living kidney donor, especially when the age is less, when the person is younger than 30 years of age. Also for family planning and pre-implantation genetic diagnosis can also be made. And it is not recommended to do in all patients, but if genetic testing can done, it can confirm the diagnosis. But no, if classic presentation is there, it is not necessary to do genetic testing in all. So atypical presentation with without apparent family history or atypical imaging pattern, in that permutation combination of various mutation can be seen, like PKD1 or PKD2 or any other gene, or presence of some other cystic disease that can be found out, or somatic mosaicism can be seen, or digenic or polygenic inheritance can be there. So in cases when there are severe early presentation or syndromic presentation, or where the discordance between the size and the function of the kidney, in such cases genetic testing should be done. So absence of positive family history pose a diagnostic dilemma in around 10 to 25% of suspected ADPKD patient. In our patient, if we see, there was no clue on ultrasound other than the small liver cyst was there. Normal GFR was there. She was in her sixth decade of life. So even if she wouldn't have come for kidney donation plan, she wouldn't have been detected also. No family history of ADPKD to suspect in such patient also. And CKD was there in a family member at the age of, in the third decade, at the age of 23, 24, that too with a very short history with shrunken kidney. And no other assistance, so likely to be of a different etiology rather than a cystic kidney disease. So to summarize this, diagnostic criteria of ADPKD are there. The sensitivity is good, but still they are not foolproof. And in scenarios where family history is absent, mild disease is there, or atypical imaging findings are there, then that can create a diagnostic dilemma. And to make a better understanding, to make a proper decision, we need to put all things together, the clinical, the imaging, genetic information, so that a better decision making can be done. Thank you.
Thank you very much. Dr. Shiji, you want to add some things?
Yeah, the only thing is, no, we had a problem with this patient because in our system, there is a significant delay in the CT angio getting reported. So this patient completed evaluation. There was no suspicion of polycystic kidney disease. And the urologist also looked at the images. They looked at the kidney and we didn't suspect. But when the surgical planning happened, only the CT angio, we asked for a report, and then we were surprised with that there are multiple cysts everywhere. So we had to abandon the procedure. Then we evaluated. The daughter, we didn't ask for the daughter siblings to donate, but then the family discussed, and after an year, the elder sister came to us saying that, can you consider me as a donor, and will I be fit to be evaluated? Can you evaluate me? Basic evaluation was again normal, but then in the background of polycystic kidney in the mother, we wanted to ensure that it is ruled out. Ultrasound didn't show anything. She was 33, so that if you look at it, can suggest that it may be okay. But then she didn't have money to do genetic testing also, so we got the MRI done, which again showed that there are very small cysts, and in the context of family history, that will be ADPKD. So looks like a less severe form of PKD mutation is documented, but a less severe form of ADPKD. We decided not to accept the donor, but it's also, some people may say that the mother is 57, 56 now, GFR is 100, cysts are hardly made out. Why don't we allow her to donate? I don't have a clear answer for that, but we decided not to do that. That's it. So the thing is, we may be missing a significant number of ADPKD, not in the context of a donor also. They don't have, this patient, none of them had any hypertension, no cysts, nothing discernible from reasonable evaluation. So that I thought is worth emphasizing. That's why we wanted to present the case. Thank you for allowing us to bring the case to the forum.
Thank you, sir. Thank you, sir. Thank you for bringing this case. Actually, it is an eye-opener to look for it, actually. Subara, sir, any your comments?
I think I have to tell you another story. This was in 1996. The patient was ADPKD, waiting for a transplant. Their son was about 27, 28 years old. So he wanted to donate. So we looked at the ultrasound, we looked at the CT scan. There's no evidence of any cysts in either in the liver or on the kidneys. But we are not very sure. Those days, genetic test was not available. So, and then we looked at the literature, and then the literature says that the polycystic the cysts appear at the time of the birth. And many of those autopsy series, they found the cysts even in people who have the ADPKD when they died in some other reason for, very young age, even in 10 years, 15 years. So we did a biopsy on him. So biopsy did not show any cysts. Then we proceeded with the transplant. And then for next 10 years, he followed up with me, and there were no cysts developed after that. So this is how we proved histologically that there were no cysts in the kidney. We did a biopsy, and the biopsy was pristine. There were no evidence of any microcysts in the kidney. So this was in 1996.
Okay.
So I think the making a diagnosis of ADPKD is not very difficult nowadays, but those days, yes, with very very primitive imaging procedures, we probably missed many cases.
Dr. Shidit, when you advocate genetic mutation testing in a patient with the ADPKD as a native kidney disease for a recipient, for a donor in his family, when you advocate genetic mutation testing for the donor?
Certainly for ADPKD, when the diagnosis is evident, and not in the context of donation, we never do that practically. I believe it is not necessary for either diagnosis or for prognostication or to decide as of now, unless you are very specific about using the pro-PKD score. we can manage that also with the Mayo score. That also doesn't require the genetic mutation. So there are multiple doctors, nurses, students who have asked me, and I've told them, if you want, you can do it. But if you ask me, is it necessary? My answer is no, for management purpose, practical purposes. But this context is different. So when there is something atypical, like for example, you have a kidney donor from a family of ADPKD, and the preliminary evaluation is not showing, then I think like we try to do in this patient, and there are the atypical presentations. We have had actually patients presenting in infancy. I have seen at least one child. There is another child who had cysts only in one kidney. So these atypical presentations are not unheard of. So I would say, if you are finding something which is what we usually see is middle-aged people, multiple cysts in both kidney, without family history, it is fairly straightforward. I can't remember doing genetic testing any of those patients, but we do, very rare, but we do come across atypical presentations. Like cyst only in one kidney is what something we have seen. Very young age, very small children is one. And the other thing which we have seen is disproportionate, where the kidneys are huge, but the GFR is normal. That also, I remember one patient where the tummy was so huge that he was unable to eat, but his creatinine was 0.91 milligram. The other way around is also possible, like Dr. Piyush was pointing out. The kidneys are not very large, cysts are there, but then the GFR is very low. So there's a discordance there. So there are some clinical situations where I think it will be worthwhile, because there may be mosaicism, there may be digenic inheritance, there may be some other, like the daughter is having a glomerular disease. It's possible that there is ADPKD as well as a genetic disease in the, glomerular disease in the family. So there are some, I think, some situations where we really need to do the genetic test.
Interesting.
I think that there is a religious context also. This ADPKD is very common in Scandinavian countries. It's about 2 to 3% of the population, and some of the families refuse to do undergo genetic testing because of the religious belief. They're saying that this has been given to us by God. Whether it's there or not, it's none of my business. It's God. So there is also context, a religious context about this genetic testing in ADPKD.
Okay. Thank you, Dr. Piyush and Dr. Srijit, for the bringing it and a good presentation and eye-opener to look into that. And thank you very much for your presentation. And if further questions, we will come to the end of the session. And this session saw two speakers. One is interesting and a veteran in nephrology who presented his experience on low-dose tacrolimus, which sounds very good. And his data is also interesting to look into it. And the discussion, we had a subsequent discussion over that. And as we don't have a robust evidence of what is the ideal TAC level, and we are still following the Western standards. And this need to be evaluated, and we need to have a large data on that to set a ideal TAC for the patients and all. And the second presentation we had with ADPKD, and not picked up by the routine ultrasound, but picked up by the CT angio. And again, it was turned up to be, and following genetic testing, she is found to have a ADPKD, but recipient is not having an ADPKD. And subsequent evaluation of the family members also evaluate and found to have a PDK. So interesting points to ponder in this session. And we hope that all of our numbers from that. And thank you very much, speakers, for their wonderful presentation, and the panelist, Dr. Subbarao sir, who has given his valid inputs, and the delegates who have attended this meeting, and MQ team for providing the technical support. And as usual, next month we'll be having the meeting on the first Saturday. And thank you one and all for your presence and your active participation in this meeting. Thank you very much. Good night. Good night. Good night. Good night, sir.
Thanks a lot.
Good night, sir. Thank you. Good night, sir.
Thank you.
Good night, sir. Thank you, sir.
Thank you, sir. Thank you, sir.